Our next speaker is Dr. Nirupama. Yeah.
Dr. Nirupama, she is additional professor of ophthalmology at the Jipmer Institute, Pondicherry. She will be speaking on approach to patients with optic disc edema and pallor.
Very good afternoon. So I'll be discussing about approach to optic disc edema and optic disc pallor. How do we go to the next? Yeah, so what is the definition of optic disc edema? It is the axonal swelling or edema of the nerve fiber layer at the optic nerve head due to optic neuropathy of any etiology. So, optic disc edema is a wider term, but the term papilledema is used when optic disc edema occurs because of raised intracranial pressure. And there is also another term called pseudopapilledema, where there is an appearance of a disc swelling, but there is no true axonal swelling or edema of the nerve fiber layer. So, this can be bilateral, as you can see here, or unilateral disc edema. And the first and foremost thing is to know the causes. What causes optic disc edema? So once you know, then when you encounter a clinical situation, you can try to correlate what could be the etiology and then order appropriate investigations. So we can divide the etiology based on the unilateral or bilateral presentation. So unilateral presentation, it is always important to rule out an asymmetric papilledema because most of the time papilledema will be bilateral, but rarely it can be asymmetric, giving the appearance of a unilateral disc swelling, or sometimes when there is an olfactory groove meningioma, the tumor can compress the optic nerve on one side, leading to a compressive optic atrophy. And simultaneously, because of an intracranial space occupying lesion, there is a raised intracranial pressure, which leads to papilledema on the contralateral side. So that is known as Foster-Kennedy syndrome. And that can also be a unilateral presentation of papilledema. Then you also have atypical optic neuritis, which can be because of infectious etiology, or if there is an optic perineuritis or neuroretinitis, again you will encounter a unilateral disc edema. And ischemic causes like NAION or AION and central retinal vein occlusion, the variation known as papillophlebitis can present with only disc edema and hemorrhages and cotton wool spots around the disc. And of course, diabetic papillopathy, all these are ischemic causes of unilateral disc edema. Then you also have compressive lesions, which can initially present with disc swelling and then it can end up with an optic atrophy. So, condition like optic nerve sheath meningioma, or whenever the compression is within the orbit, usually it will tend to give rise to a disc swelling. But when the compression is outside the orbit at the level of the chiasma or the optic tract, then it will just give rise to a descending optic atrophy. And even in hypotonic maculopathy, you can get a unilateral disc edema. And coming to the bilateral etiology, the first and foremost, the most important one is the papilledema. And it is also important to check the blood pressure of the patient coming with bilateral disc edema because grade 4 hypertensive retinopathy can give rise to this picture. And it's a very simple test which can be performed in the OPD, and immediately you have to refer the patient to the physician, and a control of blood pressure is important. Then you also have a bilateral papillitis, which is more common in children following a viral illness or following vaccination, which can present with bilateral disc edema. And then we have the other etiologies like nutritional, toxic, infiltrative, especially in systemic malignancies like leukemias, where you can have infiltration of both the optic discs. And there is congenital hereditary optic neuropathy known as Leber's hereditary optic neuropathy, where initially it will present with optic disc edema, which can be asymmetric or sequential optic disc swelling, and it will progress to an optic atrophy. So, why it is important to diagnose papilledema is because if it is the acute fulminant presentation, it can rapidly progress through various stages like early, established, chronic, and finally result in atrophic papilledema, where the patient loses vision and it becomes an irreversible blindness. So, early identification of the cause of papilledema and addressing it is very important to prevent blindness from this condition. So, what is pseudopapilledema? Pseudopapilledema also can be again unilateral or bilateral. So, the most common cause of pseudopapilledema is optic disc drusen, and we'll come to that in the subsequent slides. Other causes include small crowded discs, which are commonly seen in hypermetropes, where the disc size is small and there is crowding of nerve fibers, as you can see in this picture. So, the end-on view of the optic disc gives the appearance of a disc papilledema because of the hyperemic disc with obscuration of the cup. Then in myopia also you can have a tilted disc, which also gives rise to a appearance of a swollen disc. Similarly, in myelinated nerve fibers, the disc margins are not clear, so we get confused whether there is a disc edema there. And also whenever there is a vitropapillary traction. So all these are important causes of pseudo disc edema which have to be ruled out. So what is the aim of our clinical evaluation is first to identify whether it is a true or pseudo disc edema, then to check whether it's unilateral or bilateral, and then think of the various differential diagnoses and order appropriate investigations. And finally, if you can identify a treatable cause, it will definitely help in improving the vision of the patient, and it also helps us to give the visual prognosis. So, what is the step-by-step evaluation? First is you take a proper history. So, whenever the patient gives history of any positional headache, especially on bending down and associated with nausea, vomiting, pulsatile tinnitus, or transient visual obscurations, which is also known as amaurosis fugax, then we have to think of raised ICT and papilledema. And when it is associated with bilateral sixth nerve palsy, the patient may also complain of diplopia. So all these are clues towards papilledema. Similarly, you also take a history of any systemic symptoms and also any medications like oral contraceptive pills or oral steroids or even vitamin A therapy. All these can also give rise to a benign intracranial hypertension. So all the optic nerve evaluation tests should be done. So whenever there is a decrease in the visual acuity associated with a RAPD, that is relative afferent pupillary defect, or there is abnormality in the color vision, contrast vision, or the visual field testing shows visual field defects, and the OCT RNFL assessment also is abnormal, then we know that it is a true disc edema, and that helps us to differentiate from the pseudo disc edema or the pseudopapilledema. Fundus examination gives lot of clues. So if you get a bilateral disc swelling associated with hyperemia, disc edema, and there is obliteration of the cup, there is no cup, and you also see obscuration of the blood vessels which are around the disc, that gives more clues towards a papilledema. And you will also see sometimes hemorrhages, cotton wool spots, and also peripapillary wrinkling known as Patterns lines. So these all are pointers towards papilledema. And you should also check for the spontaneous venous pulsations. So that is checked by looking at the vein which is exiting near the disc margin, and if you're not able to pick it up, you can also give a gentle pressure on the eyeball, and that will actually elicit the spontaneous venous pulsations. So if it is present, then it is a reassuring sign that there is no raised ICT, but it may be normally also absent. So the absence of SVP is not of much information to us. Then if it is grade 4 hypertensive retinopathy causing disc edema, definitely you will see the AV crossing changes, arteriolar attenuation, and the venous compression at the crossings, along with some retinal hemorrhages and hard exudates. So all this gives the picture of the hypertensive retinopathy. Then we also can pick up other causes when it's hyperemic disc edema. unilateral presentation in a middle-aged person also gives an important clue. The other eye will be small and crowded, and that is known as a disc at risk. Whereas if you get a very elderly gentleman or a woman with a pallid disc edema and associated symptoms of temporal headaches or polymyalgia rheumatica, then it goes in favor of an arthritic AION because of giant cell arthritis. Similarly, we can see the fundus picture of hypertensive retinopathy and central retinal vein occlusion. So all these are the fundus findings which clinches the diagnosis. So in the fundus, it is very easy to detect superficial drusen, which appear as refractile bodies, but the deep and buried drusen are more difficult to identify. So if you carefully observe, there will be a nodular margin of the disc, and there will be no obscuration of the disc vessels at the margin of the disc. And also there will be no microvascular changes like hemorrhages or cotton wool spots. And the disc usually tends to be little small and crowded. And also the branching of the vessels may be slightly anomalous. So all this gives rise to a picture of an anomalous disc with buried disc drusen. So that helps to differentiate from a true disc edema. So sometimes this Vogt Koyanagi-Harada syndrome can present with bilateral disc swelling. So it is important to dilate and look at the periphery of the fundus, because sometimes I have seen postgraduates writing the diagnosis as bilateral disc edema and diagnosing it as papilledema and referring to the physician for neuroimaging. But it is important to check for peripheral serous retinal detachments. And also when you do the fundus fluorescein angiography, you'll get the starry sky appearance. So that clinches the diagnosis of Vogt Koyanagi-Harada syndrome. So other useful tests are the fundus fluorescein angiography, where you can pick up disc drusen by the autofluorescence. Even before injecting any dye, you will see the fluorescence, which is very classical of disc drusen. And also the fundus fluorescein angiography for the drusen will show staining pattern in the late phase, whereas in true disc edema there will be a diffuse leakage and irregular margins. So that helps to differentiate a true versus a pseudo disc edema. And in arthritic AION, you will also see this choroidal non-filling and hypoperfusion because of ischemic optic neuropathy. The B scan is also a very simple tool to differentiate the pseudo papilledema due to optic disc drusen, where the calcification is seen here as with acoustic shadow. And in true papilledema, you will also see a crescent sign because of fluid around the optic nerve head, which can be easily picked up on the ultrasound B scan. The OCT RNFL measurement is very useful to document actually the amount of edema, and also the serial follow-up will also tell us whether there is resolution or worsening of the disc edema. The newer enhanced depth imaging OCT actually helps us to visualize the deeper structures and can also help in identification of drusen and true papilledema. Neuroimaging is a very important aspect to find out the cause of the papilledema. So you will see the perioptic fluid around the optic nerves because of papilledema, and there will be actually the flattening of the posterior sclera. And along with that, you may also see the cause of the papilledema, that is the intracranial space occupying lesion or a tumor. So all this can be picked up on neuroimaging. In benign intracranial hypertension, you will see perioptic widening of the spaces around the optic nerve, but also a partially empty cella can be picked up. And also when you are suspecting cortical venous thrombosis, you need to do an MR venogram, which will help in identifying the venous sinus thrombosis. So in unilateral cases like this neuroimaging, it shows an optic nerve sheath meningioma. So you will see the tram track appearance and diffuse thickening of the optic nerve sheath. So now once we have identified it as a true optic disc edema, after ruling out disc drusen, it is important to do the neuroimaging. So if you get an abnormal neuroimaging, you know the etiology is either a tumor, that is an intracranial space occupying tumor, or a benign intracranial hypertension, or even other causes like I showed, optic nerve sheath meningioma. But if the neuroimaging is normal, then you can think of other etiologies like ischemia, inflammatory or toxic causes giving rise to a disc edema. So now coming to the management, once you have diagnosed optic disc edema, you should identify the etiology, and once you know the etiology, you have to manage accordingly and fix the etiology. If it is a tumor, we have to refer to neurosurgeon for neurosurgical intervention. If there is a medical cause like meningitis, appropriate antibiotics. If it is a cortical venous thrombosis, then you have to start on systemic anticoagulants. And if it is an inflammation, then like Vogue Koyanagi Harada, then the treatment is of course steroids or immunosuppressants. If it is because of idiopathic intracranial hypertension, then the treatment depends on whether the patient is having vision loss or there is no vision loss. So if it is no or mild visual loss, then we can go ahead with the medical management, and we can give oral acetazolamide along with treating the obesity by ensuring that patient loses weight, advising weight loss measures, and also give a salt restricted diet, and then follow up the patient serially for resolution of the papilledema. But if there is a visual loss and it is associated with headache, then again we have to refer to a neurosurgeon for a ventricular peritoneal shunt. But if there is no headache and it's only a progressive visual loss, then we have to go ahead with an optic nerve sheath fenestration surgery, which can actually prevent the progression of visual loss because of the papilledema. Now coming to the approach for optic disc pallor. So optic disc pallor occurs because of a sequelae of various optic neuropathies or optic nerve disorders, and it can be a partial or a total optic atrophy, and therefore the pallor also may be mild, moderate or severe depending on the extent of the optic atrophy. And sometimes the pallor may not correlate with the optic nerve function, like sometimes it may be the vision may be very poor and the pallor may be only in the temporal area. So that should be kept in mind. And the signs and symptoms also may range from subtle visual loss to total blindness. And sometimes it may be an incidental finding which is picked up on routine ophthalmological checkup. So we all know the normal color of the optic disc is a pale pink or a salmon pink color, but when there is an optic pallor, it becomes fully pale because of capillary dropout, gliosis, and also increased visibility of the scleral lamina. So the aim of the clinical evaluation is one, again, to rule out true optic disc pallor from a just pseudo appearance of the disc pallor, and identify any ongoing process of optic neuropathy like toxic or compressive optic neuropathy, because if you identify, you can stop the progression by treating the cause. Or sometimes it may be the pallor may be because of a previous insult which has occurred in the past, like a past episode of an ischemic optic neuropathy or trauma. Like we had a patient who had a road traffic accident and he had a lower limb fracture. So his attention was diverted towards the limb fracture and he didn't realize the diminution of vision. And later, incidentally, he realized that the vision was low in one eye, but he was referred by another ophthalmologist to rule out amblyopia because the pallor was very subtle in the patient. But when we did the complete evaluation and the field testing, actually we came to know that it was an optic neuropathy. And then when we asked the past history, the patient told he had a road traffic accident. So patient may even forget the previous history of the accident, but then you have to recheck and then confirm the diagnosis that it was a traumatic optic neuropathy. And then we need to order the appropriate investigations and also explain the prognosis to the patient. So a careful history and examination is important to identify the etiology. Then just like disc edema, we have to do all the optic nerve function tests, and the appearance of the disc pallor gives us a clue to what the etiology was, and the diagnosis of optic atrophy into primary, secondary, and consecutive or a cavernous optic atrophy is just by the base on the appearance on fundus examination. Like in primary optic atrophy, the disc will be well defined and there will be a diffuse pallor and arteriolar attenuation. But in secondary optic atrophy, it's a dirty gray appearance with blurring of disc margins and also sheathing of the blood vessels. Then we know it is secondary to papilledema or papillitis. Whereas if it is this cavernous optic atrophy, then the etiology is either glaucoma or because of sometimes methanol toxicity, or rarely even following compressive optic atrophy, you may get this kind of a cupping associated with the disc pallor. Whereas
Dr.
we all
Nirupama, I think next session people have come.
okay.
Yeah.
So bilateral disc, temporal disc pallor can be a normal finding, but because it is due to the papillomacular bundle coming to the temporal disc, it should be kept in mind for toxic etiology. And also remember, the pseudopallor can occur in high myopes or also sometimes in optic disc pits or disc drusen. And finally, the comprehensive evaluation and treatment is a key approach to optic disc pallor.